I'm going to start with the delivery. Actually, I'll start with the patient chair. Then I'll move to the unit and the cabinetry and how it's set up, and then we'll end with the light, okay, and the monitor button. Okay. This unit and this setup is identical to what is in the closed room. Closed room will be telescope, video,
simulcast.
Simulcast.
Mm-hmm.
That's the word I was looking for. To the auditorium. Okay. So on the 3000 chair, okay, we have two forms. And what I talk about with that is we have a narrow back or we have a wide back. Okay. We have one of the wide backs in the closed room, and all the difference is the wide back has a larger upholstery set in back. Everything else is identical. Okay. We particularly, I think I went with that conversation and concept because narrow back is probably 80% of what we see go out the door. The wide back is for particular people who feel like they want more support on the patient, or if we're anesthetizing the patient, they want to have ultimate support on the shoulder and the elbows. So that's where I see the wide back get used. So we can stick our head in there in a second and see the difference. It's going to function identically. Okay. The first thing I talked about, where we have controls on the rear delivery cabinets, okay, are only on the chair. Okay. On the units up front, there's a touchpad that is standard. Okay. On the unit itself, and I'll go over that in a minute. But on the chair, or for the rear delivery environment, I've got a touchpad on the operator and a touchpad on the assistant side. Okay. I always say that these touchpads are in the field of play, meaning that if the operator's in the oral cavity using a rotary instrument, they can inadvertently hit one of the directions, and that can move the patient, and that would be a bad thing. Okay? So we have this touchpad go to sleep after 7 seconds of non-use. Okay? So I have a secure touch button right here. It's a big oval. I hit that once, and that brings that chair back to life. So now, every time I hit an arrow, I get a fresh 7 seconds. So I don't have to trim the patient in that regard. Okay, I don't have to worry about getting it there. Position 0 is going to be set as exit out of the factory. Okay, these can all be reprogrammed. Position 1 is going to be a gross supine. It tends to be what we try to set up for the maxilla. Okay. It's going to be fairly low, almost, it's going to be past. Well, this has been adjusted. Nice. Okay. But I can continue to go back much further, and I can take the chair down lower if I need to. Okay. Once that 7 seconds is up from here, then that touchpad will go to sleep. This is something that's going to take you probably 2 patients to get used to. Okay. If you're using the ones in front, the touchpad that's on the delivery unit never falls asleep. It is always on. Okay? Dr. Todd, did you find that easy to get used to on yours? Okay. So, position, let me go through the positions again, I apologize. Position 0 is going to be exit. 1 is going to be maxilla or gross supine. Position 2 was set up for the mandibular. I think it's off. Position 3 is just set up for cleaning. Clean the room at the end of the night. Chair goes high. We can reprogram that, and we could do a Dr. Engel position 1, Dr. Pitts position 2, and X-ray position 3. It's something that we can morph and work with, and you can give me suggestions. Okay. Below the touchpad and the directions is a padlock here. And this padlock is the solenoid for the chair swivel itself. This is an identical touchpad on the opposite side. So when I hit that, okay, that's how I can rotate the patient to more of a, say a 12 o'clock position or an 11:30 position. Instead of me moving around the patient, I can move to this. If I'm working in the rear delivery rooms, I'm almost certainly going to have the chair angled slightly. Okay? It allows better access for the operator and allows the assistant to move in tighter and have their work surface in front of them.
One thing that I might add, just to so you guys know, in case Tim forgets to say this, is that if that rheostat cord is underneath. There's a safety. You want to take over? You want me to finish?
You're doing great.
Okay. There's a safety mechanism so that the cord doesn't get pinched, where if it feels the cord, it will stop. So sometimes if you can't get the chair all the way down, it's because that's in the way. Pull it out and then drop it.
Okay. It's a great segue. One of the things that it will have, the other side of this, the safety switch is if we are bringing the patient down.
As you can see right there, it comes out of right there. So if that chair feels it, it will stop.
Right. Or if the rheostat is stuck up under the base, which will happen after cleaning. Okay. Or if we exit a patient, okay, and the assistant's not paying attention, or the doctor, and all of a sudden my foot comes in the way, it will not allow the chair to go down. Okay? So, inevitably, probably once a month, I get a phone call from one of my offices. My chair won't move down. The safety switch just needs to be released generally. Okay? And it's something that the cleaning crew can bang into. They can get caught.
Massagers on any of these?
All of it. Yes, sir. Okay? So that's the last part is on the, before I segue into what Dr. Todd just brought up, the last part is on the headrest itself. Okay, I have a dual articulating headrest. It's a lever mechanism. I'm going to depress that way. I can articulate the head forward,
Wow.
backwards. Okay? It's not bolted down. If we were to bring in a wheelchair patient, it gives us the capability of turning the headrest around, or removing if we have a pedodontic patient. And this gets into that.
I noticed that with the kids. For me, I take it out so I can get closer to them.
Okay. One thing that to point out, okay, is when we are entering and exiting a patient, I have this set up just for the demonstration here, but I have a lever on the armrest. Okay, I would ask that you release the lever and move this backwards. This is going to allow easier in and out of the patient itself. They don't have to move around the armrest in that fashion. Okay. Also, on the narrow back chair, something will happen. If I get a taller patient, if I get a 6'4" patient, they may have a tall torso, pulls their elbows up. Their elbow may miss the armrest right here. And this is designed to be an elbow cup. That's why it's angled in. Okay. So if I get somebody who's tall like that, I may miss their elbows. I can move both armrests back to capture the elbow. If you capture the elbow, you support the shoulder, and that's going to promote a much longer procedure. Okay, does that make sense? Questions? Comments? Making it awfully easy on me. That's fun. Okay.
How